So what makes the jaw so different? Well, obviously it's different because we've got teeth in the area, but that makes a lot of drama. If you took 32 teeth and drilled holes and got them to become sort of implants up and down the femur, and once they were embedded in the femur, you tried to move those around orthodontically, they wouldn't move at all. That was tried decades ago. You cannot do that with bone. But alveolar bone, you can, because we know because of bisphosphonate research that alveolar bone turns over in some individuals as much as 10 times faster. And we're talking about older people now, not young kids. And orthodontics works fine. You could be 65 years old and you can still get your teeth to move. And perhaps that's one reason that bisphosphonates cause damage to the jaws. I think inflammation is probably a bigger, or trauma is probably a bigger reason, but that's got to be some factor, because if you have a lot of fast bone turnover, these drugs make the osteocytes and osteoblasts sick. And if you've got some that need to be very healthy because they're working all the time and you make them sick, then maybe that's a bigger problem than in other settings. But we also have, without a doubt, more tumors and cysts than all the other bones combined, because of all the odontogenic stuff. I mean, especially when we talk about cysts, it's a huge number. We have, MD Anderson has it's essentially the premier head and neck pathology, cancer pathology fellowship. They take one fellow a year. This year they took 2. And those people, those fellows come over and spend a month in our offices in the dental school because they want to learn about all the other stuff, the non-cancer materials. And they're fascinated by all of these cysts and odontogenic tumors. They weren't trained in any of that before they get to us. And we have some of those cysts that make a big difference. An odontogenic keratocyst is a whole different animal from a routine dentigerous cyst in its biological behavior. So we've got that. I think it just makes the jaws more interesting. We have more infections than all the other bones combined. You don't get an infection in the bone. In kids, bone infections, about 85% of the time, are from blood-borne bacteria. And kids have different bones, they're a lot more porous, so it's a whole different kind of osteomyelitis, and it's pretty uncommon. In old farts, it's a different story. It's only if you have an exposed bone, you have a fracture, or you had the prosthesis put in, or somebody put some augmentation material in there, and you got an infection from that. So it's the number one bug producing osteomyelitis of long bones today is from the skin. Strep epidermidis. It's probably 75% of all the osteomyelitis in adults. Just think about that. And we're dealing, I mean, how many times have you seen exposed bone? Tons of times. And that's the number one reason for osteomyelitis in long bones. Kind of an interesting phenomenon. I mean, the long bones, if you have a bone sticking out, the primary prerequisite is to get that bone under the skin again, so that your chances of more bacteria coating that bone is diminished. So we have lots of infections, and we have this kind of stuff. Yeah, that's not a West Virginia patient, it's an Ohio patient. I just wanted to make that all clear to everybody. But if you have this kind of stuff going on for years and years and years, right next to the bone, I mean, that's a pretty unique environment. And also more trauma. If you count extractions and all the surgeries, periosurgery, endosurgery, whatever kind of surgery, we're far ahead of the whole rest of the skeleton. I mean, we have more dental implants placed than hip implants nowadays. And that's a pretty strange phenomenon for a guy who's been in dentistry as long as I have. And sometimes we have massive numbers of implants placed. We have more exposed bone than any other place in the body. We have more implants than all the other bones combined. And we're the only bones where people put stuff next to them. One of the cocaine and crack diseases that I published, I'm trying to get it into the ATA journal. I haven't submitted it yet, but I think it would make a nice little paper there. We called it cocaine osteonecrosis. It looks just like bisphosphonate-related osteonecrosis. You have this exposed bone, not a whole lot of inflammation of the surrounding soft tissue. The bone just remains exposed forever. Somebody gets in a bar fight, they lose their 2 front teeth. A year later, you're still looking at white bone, maybe gray bone. And then when you ask that patient, do you put anything in that place? You and I wouldn't have bothered, or wouldn't even have thought to ask that of a patient. But C.D. Johnson knows his group, and 40% of the people in our urgent care clinic are addicts, drug addicts, including alcohol as an addiction. And so he asked those questions, and we have 3 cases of cocaine-related osteonecrosis of the jaws, smack dab where they put their cocaine. And it also is the only bone with large sensory nerves. Every other bone in the body, every single other bone in the body, if you cut through the periosteum and the cortex, you could scoop out the entire marrow space without any anesthesia. There is no pain sensation inside bone marrow. There are no fibers inside bone marrow. All those fatty cells are like tomatoes in a basket. They don't need, with their rigid structure and the flexibility of the cells, they don't really need fibers to hold them all together. So there are 0 amounts of fibers inside the marrow spaces. If you find fibers, if we found fibers before this whole ischemic research explosion, if we found fibers when I was a resident back in the 70s, early 70s, we would worry about this as a pre-leukemia, because that's what our history told us. And we now know that leukemia, when you have leukemia in bone marrow, it produces a local ischemia in the marrow, and the fibers are a response to the ischemia, not a direct response to the leukemic cells. So we have the only bones with these big sensory nerve fibers. Does that cause a different kind of pain? Well, if you look in pain books, this came from the premier one from about 10 years ago. It's no longer published, but they said that 85% of all of the neuralgias in the human body are in the head and neck region. Maybe that has something to do with the fact that we're not only dealing with nerves inside bones, and bones that have all these issues going on, but it's all the same nerve. So you can have damage to the inferior branch of the trigeminal nerve. And they've even taken, you can have bacteria, you can have cytokines traveling all the way up to the Gasserian ganglion, and then give you sensations of a problem in the other arch. And it is pretty well documented, even with trigeminal neuralgia. You know, the #1 model, you're not allowed to do it anymore. Animal research in universities anyway won't allow it to be done. But the animal model that came out of the 70s, Dr. Black from the University of Washington, the animal model for trigeminal neuralgia for the 60s and 70s was the first time they really had a premier model for that particular disease, was to take cats and break off 3 lower molars, 3 teeth, and then just let them fester. And they would all develop symptoms of trigeminal neuralgia. And there are lots of cases in our literature where people came in with toothache, and the physician called it trigeminal neuralgia and was treating it in that regard, and yet nobody bothered to look at the teeth and find out whether there's pus at the end of this tooth. The symptoms were the same as trigeminal neuralgia. And that's one really major nerve. 40% of all the sensory input into your brain comes from the trigeminal nerve. And we're ripping it and cutting it and squeezing it. We're doing all kinds of things. And every time we pull a tooth, we're just ripping that nerve. And no problem. It's one of the places where radiation is used fairly routinely because of MD Anderson. They were the first place back in the 60s that combined, the surgeons and radiologists actually were friends, and they determined combined treatment with surgery and radiation for head and neck cancers. And that is still very, very common today. So we get more radiation because of that than all the other bones combined. And what other bone has some person putting vasoconstrictor right next to it? designed to reduce the blood flow by 75%. And if somebody has really a lot of dental problems, you can have that a lot. I've been getting my teeth fixed up before I retire and put in about $9,000 worth of new dentistry this year. So I've had a lot of vasoconstrictor put in my bone. And that's fine for everybody. We don't have many problems. But I haven't really recorded them, but I'll probably have talked to 80 or 90 people in my lifetime whose pain, facial pain, lasting for years, started with a simple occlusal amalgam or plastic. And working on the tooth, I called these dentists and I said, how deep did you go? And there's no reason to think the pulp was involved. The pulp test's fine. But why do they still have that pain? And the only thing I can think of is those individuals happen to have really poor blood flowing through their marrow, probably in the whole skeleton. But they had only one place where they got vasoconstrictors. That's just a theory. There's no proof of any of that. But it does at least make a certain amount of sense to me. So that's another thing that makes the jaws unique. And we don't know that. We can't tell if somebody's got lousy blood flow through their jaws. We can tell if we see a residual socket. Somebody's 50 now, and you're working out a tooth, and you look at where the wisdom teeth were extracted when they were 19, and you can still see an outline of a socket. That's proof that there was something wrong at that age. And if you're going to have something that was wrong as a teenager and is continuing to be wrong, infection doesn't really fit that picture. But most ischemic problems, most blood flow problems, which now affect a minimum of 6% of us. 6%, so we've got maybe 3 or 4 people in this room with that problem. They're not really coagulation diseases, they're hypercoagulation states. There are about 20 of them now. And it's all brand new research. You need special tests to know that you've got these problems, so your patient isn't going to know about it. The routine blood studies, even the ones that you do for bleeding disorders before surgery, they're all normal in these individuals. I'm one of those individuals. Brad Neville is one of those individuals. Carl Allen is one of those individuals. And the reason we know about it is we got tested after we threw clots. The people who get clots in the back of their knee when they're on an airplane flight, those are people who all have these diseases, or states, if you will. And you don't know that when they come into your office, but that's an explanation. Maybe sooner or later we'll come up with a nice cheap test that will tell us, give us that picture. But right now, if I suspect an ischemic bone problem in the jaws, I have to send a patient off for $4,000 worth of tests. And that's just not going to happen, unless it's a life-threatening problem. Why would these hypercoagulation states, I'll talk about them in more detail in a little bit, but they only produce small clots. Your fibrin, mostly it's fibrin, so if you take aspirin, it doesn't really help. That's only good for platelet problems. And the fibrin just doesn't break down fast enough. All of us right now have maybe 1 billion little clots formed every second in our bodies, and they're instantly dissolved. There are 3 fail-safe systems. It's really a good system. But if one is a little slow, then as the years progress, you just get a little worse and worse and worse, and you may go to your grave with no problem. But if you have an auto accident when you're 65 and you have all these inflammatory cytokines, some of those cytokines are telling the body, hey, we need a lot of clotting here because we've got damage. And if you're one of those 6 or 7% of us, then you could have way too many clots, and it could be the reason you die. Disseminated intravascular coagulopathy after pregnancy, for example, septic shock. Those are people with these diseases, and they don't know it when they're having a baby either. Why is the bone susceptible? There are two tissues that are really susceptible to that kind of thing. Bone marrow is one, and it's because bone marrow has only small capillary beds. There are very few major vessels in bone marrow, and this is a small clot problem. So the clots really stop the blood flow in one little capillary bed, and it causes pain. But how are you going to see a capillary bed? There's no tests we can do that will show that. The brain, of course, for different reasons, is another. Why is the bone more susceptible? If there happens to be a little problem, then you're going to have swelling, you're going to have edema. And just like a tooth, all of us understand if you knock on a tooth too hard, you're going to get edema in that tooth and the veins are going to collapse. The arteries will remain open. So you get blood in, but nothing coming out. And that's going to end up with a lot of fluid being pushed out of the vessels. And that happens in the bone as well. We just don't think about it as happening in the bone. So if you give somebody corticosteroids, every fat cell in their body increases by 10 to 20%. My wife's on steroids for lupus right now. She's developed a little buffalo lung. She's gained 30 pounds in a year. And that's all water weight, water retention, and the puffiness is in part because of all the fat cells being bigger. Well, if you have fat cells in bone, what can happen? They can't expand. The cortex does not expand in that setting, so the veins collapse, the weakest structures collapse. And you get backup pressures and stagnation, and that all leads to even more clots. So that's a whole fascinating thing that has to do with bone ischemia. And of course, we've got radiation, osteonecrosis, and we have some very unique ways of testing. Diagnostic anesthesia. Just last week in our dental clinic, urgent care, they called me down. There's a patient in so much pain that she hadn't slept in weeks. She just has to get exhausted. That's the only way she can sleep. It is not trigeminal neuralgia, but it's been diagnosed as that. She's been to at least a dozen docs, 14 months she's been in pain, and a lot of dentists that looked at x-rays and say, there's nothing wrong here. And I put a little diagnostic anesthesia in an area that looked a little rough on the surface, an old extraction site, and the pain disappeared completely. Diagnostic anesthesia is a very specific and very easy test to do. If the pain disappears completely with you putting in just a tenth of a carpule, just above the periosteum, as if you're going to work on a tooth in that area, and the pain goes away, then you've got the exact site where there's some bone damage beneath that. And that's where you do your biopsy, your surgical exploration. And there was a paper, I met this guy because of that, Bob McMahon, back in the mid-90s, wrote a paper on diagnostic anesthesia in Compendium. And he had 48 patients. And he used diagnostic anesthesia 3 times, 3 weeks apart, or a week apart. And he pinpointed exactly the place where all the pain disappeared. Then you know by definition you have a local cause of the pain. It's not something wrong with the nerve. It's something damaging or stimulating the nerves right at that point. And if it was repeated, then he went in and did a bone biopsy. And he sent all those off, 48 patients. He sent them off to, he met a pathologist at Indiana University School of Medicine. Out of those 48 had either ischemic or inflammatory bone marrow problems in that area. So if we do diagnostic anesthesia and we identify a place, that really gives you the responsibility of talking somebody into going in and doing, doing the exploratory surgery. Let me get my voice back here for a moment. That most of the people who donate bodies to medicine today are people who have been in the hospital for months. The law doesn't allow you to do that, to take all the John Does and Jane Does and make them cadavers for medical students anymore. So you have to have somebody sign a consent saying, yes, you can have my body and do this to my body. Well, those are people who have been in the hospital so long that they don't think of their body as sacred anymore. They're just worn out. And from what he said, they're almost all ischemic for a long time. They have strokes, heart attacks, chemotherapy, cancer, all those things that produce body-wide ischemia. So he suggested that I ought to look at those jobs. So I got about 95 of them. I've got 42 processed, and this is from that study. I don't know if you can see anything abnormal here. There's a little bit of irregularity on the surface that I kind of find strange, but this is what it looks like inside. The nerve is all frayed and brown. I mean, poor processing isn't going to produce that kind of a change. Here is normal marrow, this yellowish material over here, and this was all bone marrow edema, essentially. A little bit down here as well. So this was a very damaged nerve. I have seen patients with no nerves at all. And they work fine. Mandibular block works fine. You get the numb lip and everything. Just to show how fascinating, how versatile the nervous system is. You lose a major nerve, and yet the other nerves, the proprioceptor nerves probably, are going to take up the signal. When that first was announced, neuroplasticity in the brain, in the peripheral nervous system, that was a major, major thing. Lots of excitement that I could tell from just reading the neurology literature. And then last year, they determined that neuroplasticity occurs in the mind as well, in the brain. So all of the connections, the typical connection in your brain, a single neuron, just how many connections do you suppose it has with other neurons? One neuron has 10,000. When you were born, each neuron had 6 connections. By the time you were 3 years old, you have 10,000 connections. That's how fast the brain is building. And now we know that those connections are constantly popping off and reconnecting to other cells. That's how you get your memories. And neuroplasticity is all over the nervous system. Here's a good example of it. We also have more torque than almost any other bone. The hip is the other place where you have the most pressure. And it's a certain amount of torque because of the nature of the hip. I don't know why the hip really should be up and straight up and down, but it seems to be more maneuverable with an angle on it. And so that has a bit of torque too, and the most likely places to have ischemic bone damage, the 3 places are the hip, the knees, and the jaws. The lower back is another place where it's a pretty common problem. We also have faster turnover in the jaws. I've already told you about that, and we're closer to the surface than any other bones. So, you get between the cortex. This is where I've spent 25 years of my life studying. It's pretty obvious once you look at cadaver studies. Here's a little hole, but this is what a normal cadaver looks like, a nice kind of glistening whitish nerve. The regular marrow space looks a little whitish or yellowish, and this is what it looks like when it's ischemically damaged. And this is a place where I told you histopathology is required to figure out the physiology, and it's led me to some pretty strange places. So I guess the whole emphasis, if you take home no lesson at all, just don't believe those x-rays, because you could have a little hidden something in there that's pretty hard to see unless you have a very suspicious mind.